Welcome back to the fifth episode of the 2022 CGA-IGC podcast season. My name is Beth Dudley. I'm a genetic counselor at the University of Pittsburgh, and I will be your host for this episode. During today's podcast, I will be speaking with Michael Goggins, a gastroenterologist who is a professor of pathology, medicine, and oncology at Johns Hopkins University. He is the PI of the Ep.5 pancreatic cancer surveillance study and is the last author of a recently published article about their data in the Journal of Clinical Oncology. The article is entitled The Multicenter Cancer of Pancreas Screening Study, Impact on Stage and Survival. It is currently available online ahead of print. Dr. Goggins, thank you for speaking with us today.
Thank you, Beth, for having me. Delighted to be here.
I know that those of us who live in the pancreas world with you are very excited about this paper, and I'm sure that our listeners will be eager to hear what you have to say about the data. So let's get into it. So obviously this data is partially at least based on the Ep.5 study. Can you tell us a little bit about that study for those listeners who may not be familiar with it?
Yeah, so for context, the CAPS study, Cancer of the Pancreas Screening, that study began at Hopkins in the late 90s as opened by great colleague M.B.B.CH, and it went through various iterations. CAPS-1 and CAPS-2 were like pilot studies. CAPS-3 was an initial multicenter study that opened about 15 or more years ago. And then we reverted with some small amount of funding to do some of the initial comparison of the pancreatic imaging tests. That was very valuable. And then we had to, mainly for funding reasons, much as we like doing multicenter studies, revert back to a Hopkins only study. And that study extended for a number of years. But we wanted to extend some of our early results that we had seen at Hopkins into a multicenter study. And so the CAPS-5 is a multicenter study that opened thanks to PanCan funding, the Pancreatic Cancer Action Network, in 2014. And then it's been supported by NIH funding, after those first couple of years since 2016. And so the goals of CAPS-5 have been to extend and validate, if you like, the earlier results that we'd had in the CAPS study, such as, for example, the CAPS-4 study, which was published about 5 years ago now, came out in 2017 online as a Hopkins-only study. And those were really important results. But still, the numbers are small. As you know, Beth, the incidence of pancreatic cancer, even in people who are under surveillance, is thankfully not very high. And so we have to enroll many patients for a long time. And we wanted to determine if the results we were seeing would also be seen in other expert centers, like at your center at Pittsburgh. Of course, you're part of the CAPS-5 study and the many participants. So that's what the main goal of the CAPS-5 has been. Of course, we have a significant research aspect of trying to develop better blood tests and that kind of thing as well. So sort of two parts: that what are the outcomes of surveillance, and can we eventually develop better diagnostic tests?
So can you talk to us a little bit about what the aims of this specific publication were and what study design you had?
The study design, it's a prospective cohort study, all patients enrolled into CAPS-5, many of whom were patients who had been previously enrolled at Hopkins in prior CAPS studies, and all of the different CAPS sites, Pittsburgh, Pennsylvania, Dana-Farber in Boston, Michigan, Case Western, Yale, Columbia, all these sites with their local teams of experts doing surveillance. So prospective case cohort study, and to look at outcomes. We said this time, this is the end of the first round of our program. We'd always set out in kind of our original grant proposal that we would look at the outcomes in this cohort after the study period ended. And, the main message of this study was how good can we do early detection? In particular, we were very interested in what percentage of patients who develop a pancreatic cancer have a stage 1 pancreatic cancer. And if they don't have a stage 1 pancreatic cancer, the other goal is to try and detect, if not invasive cancer, the nearest thing to this high-grade dysplasia, kind of carcinoma in situ was an old term that used to be used. that these are the patients who, if they're stage 1, of course, we think have generally going to have the highest chance of cure, and the high-grade dysplasia people, hopefully we're preventing, or intercepting pancreatic cancer before it starts to invade.
So let's talk a little bit more about the data. Obviously, I think one of the takeaways from this paper is that surveillance seems to be successful at detecting stage 1 disease, and that does improve survival. Can you give us a little bit more insight into the results from this study?
Yeah, so anytime people are diagnosed with pancreatic cancer in the surveillance, it's disheartening because we actually are really trying to prevent pancreatic cancer. And, as you know, most often we don't really have good enough imaging capability to see that any kind of suspicious lesion before there's cancer. It's often a kind of microscopic disease. But being able to detect small cancers, that are only a centimeter in size and they're localized, haven't spread anywhere, that is our goal. Of course, not everybody, even people who are following regular surveillance, achieve that. And there may be a variety of reasons for that. Sometimes maybe the tumors are growing more quickly. A lot of these patients are on annual surveillance, and that's a hard enough routine or schedule to maintain over many years. So some patients, we are a little concerned maybe ahead of time, and they are getting maybe scanned more frequently. That remains a challenge, is who should be getting surveillance annually and when should we shorten that interval? Those are some of the questions that we're trying to get. And even sometimes patients not only would present with maybe not stage 1, but stage 2, but sometimes even despite doing all the right things, you can present with advanced disease. So we certainly haven't figured out a way to cure everybody with this disease. We're still trying to learn. That's why the study continues. If you look, as many will know, at the number of patients who present with stage 1 pancreatic cancer in the general population, if you wait for symptoms, maybe only 1% or 2% of people will be fortunate enough to present with stage 1 disease. By the time it's diagnosed with symptoms, usually it's advanced, as is, of course, well known. So this is very dramatic to go from the majority of patients having stage 1 disease compared to hardly anyone.
So for people who maybe haven't had a chance to look at the paper yet, just a few quick snapshots from the data. There were about 1,500 people in the study who were undergoing surveillance. Almost half of them had a pathogenic variant in the pancreatic cancer susceptibility gene. The others, it sounded like by and large, were from familial pancreatic cancer families. And there were 10 people in the study diagnosed with PDAC. And amazingly, 7 of them had stage 1 disease. The only one with metastatic disease had been lost to follow-up. So that's comparing with SEER data. Over half present with metastatic disease in the general population, and only about 12% will have local disease. So seems pretty convincing.
Yeah, a small percentage of local disease and a smaller percent, that's sort of stage 1, 2, and a smaller percentage, and it's well under 5% will have a stage 1 disease at diagnosis. So that was 10. The one patient who presented with symptoms, he'd had surveillance and he had not had any surveillance for about 4 years, and that he presented with metastatic disease. And then, as I say, we also included the extended follow-up of patients who'd been enrolled in the prior studies, and that allowed us to really look at long-term survival. So the patients who were diagnosed with pancreatic cancer in the CAPS study program altogether, their average survival, if you took all of them, was approximately 10 years. And again, when you look at the people who dropped their surveillance, didn't maintain a kind of typically annual schedule, their survival starts to rapidly look like people who aren't getting any surveillance compared to the people who maintain surveillance. So it's really very dramatic difference.
So there were a couple other interesting things I noted when looking through the data that I just wanted to get your opinion on. As is common in pancreatic cancer early detection research, most of the participants in CAPS-5 are white. And so I wanted to just get your thoughts on whether or not we can extend this data to other racial groups, or what we should do to get data for those people.
For sure, that's a priority amongst us pancreatic cancer investigators through multiple groups. We have a number of studies. Our enrollment in CAPS has been slowly increasing. We've tried to, one of the goals of the multicenter study was to bring in centers where enrollment of minorities might be more facilitated. And we're continuing to expand the number of sites to try and get, whether it's African American or other ethnic groups. This is obviously a priority, not just for early detection, actually, but for all kinds of research. We have our Generate study through the Stand Up to Cancer, and the Regenerate study is a study looking at genetics, for example, and trying to enroll minorities. And there are many reasons, I think, for that need for extended outreach to make those efforts. I think it's also a very important question is there's no particular reason, I believe, why we couldn't do these same early detection, generate these same early detection results, or at least very similar in a minority population. In other words, for the most part, their underlying biology is probably going to be the same. But of course, these are very important questions we have to answer. And that's part of our goal. We have studies going on here at Hopkins and elsewhere. What differences are there in genetics and tumor biology? These are all very important questions between majority Caucasian populations versus minority populations. So it's a good question we have to try and continue to tackle.
So one thing I have thought to myself over time about is people who have mutations in these pancreatic cancer susceptibility genes versus people in familial pancreatic cancer kindred. So obviously over the last 5 years, genetic testing for pancreatic cancer has really expanded. So we're clearly supposed to be offering testing to everyone with pancreatic cancer. If they're not available for testing, we should be offering it to first-degree relatives. So I have wondered, as this testing is becoming more commonplace, will we start to see a divergence in risk for people with pathogenic variants versus the people that stay in that FPC categorization? My hypothesis would have been that we would, and that the FPC families would have lower risk. But the data from this cohort suggests maybe that's not true, because 6 of the 10 people from the S.5 study were in an FPC kindred rather than having a pathogenic variant. Admittedly, they hadn't all had panel testing, so maybe that would shift a little bit, but still it seems like a significant number of them don't have an identified genetic predisposition. Do you have any thoughts about what that means or what we should be thinking about it?
When we add up the S.5 with the earlier CAPs, we didn't see just on a straight number of cancers in this particular study clear evidence, although I will say for a difference. I will say a few years ago, we published a study within the CAPS program where we took a smaller number of people. This was a Hopkins only study who were in the CAPS program, and we gene tested everyone, to your point. So you have to know everybody's gene status, at least among the genes that we know, to define that. And we did. And of course, so in that group, everybody is meeting risk based either on family history or mutation status. They may have 2 first-degree relatives, 3 first-degree relatives, 1 first, 1 second, but they're meeting criteria for that, and then the mutation carriers. So, of course, if you're a mutation carrier and you have multiple first-degree relatives, maybe your risk is even higher. So the arbitrary breaking down of these into 2 risk groups is certainly reasonable, but within that, there's some complexity. But in that study, we did show that there was a significantly higher risk of having pancreatic cancer if you were a mutation carrier within the CAPS program. If you were familial and mutation, it was higher than familial alone. And I think that still holds. And again, we have from our family registry here at Hopkins, Dr. Allison Klein leads that. It's been 25-year plus effort to enroll people. And we have a lot of information about prospective pancreatic cancer risk in many, many thousands of families. And the pancreatic cancer risk is proportional to the extent of the family history. For example, this brings up the challenging question when someone naturally is concerned, they have I'm sure you get these questions, your first relative with pancreatic cancer and, should I get screened or, I had an aunt or, so the risk there is, not that we're anywhere near perfect risk predictors. It's a very imperfect estimate, but still the risk is on average low. So I think overall, having the individual having the mutation really clarifies that risk much better, as you know better than I. So I think we can still generate more data on this, family history plus mutation. That's one of the values of getting the gene testing done, as you pointed out in the beginning. both the NCCN guidelines that recommend gene testing that can help when a family history maybe alone doesn't meet criteria currently for surveillance. The detection of a mutation can be valuable and help stratify risk. So I think that basic relationship still holds. In this case, it's still relatively small numbers for that kind of risk. There's a lot of factors involved in that.
I'm really curious over the next few years to see the data that I give my patients on what their risk for pancreatic cancer is if they're in a familial pancreatic cancer cohort is based on Allison's data from early 2000s now. So I'm sure she's working on updated numbers now that we better.
She is. She has great data.
Very curious.
Stay tuned.
And then the other couple of things that I wanted to ask you about with the data, I thought it was interesting that none of the resected PDACs that were found through surveillance arose through IPMNs, which is not what we often think of when we're looking for high-risk lesions. Any thoughts on why that might be, or does it mean anything from a surveillance perspective?
We don't want to draw too much on it, but one interesting finding that we had was that when we looked at patients who had an IPMN resection and they had high-grade dysplasia, we had the whole CAPS study going back again, including the studies led by Dr. Canto, and so we're adding them all up in the S.5. So we had 10 patients with high-grade dysplasia within an IPMN, and in none of those cases was there an associated infiltrating cancer. So we had pancreatic cancers, but the 26 pancreatic cancers in the capsule, none of them were in a clear association. In other words, intimately arising from. They could have had cysts, of course. They could have had IPMNs elsewhere in the gland, but it was not thought at the resection that the IPMN gave rise to the invasive cancer. So on the one hand, it could mean that in those 10 cases where there was high-grade dysplasia, the clinicians intervened appropriately and prevented invasive cancer. But on the other hand, it also highlights something we've known for a long time, is that when you look at the total population of pancreatic cancers, the evidence we have is that perhaps 95% of them are going to rise in these microscopic panning, which, by the way, is one of the reasons why we've done many of these pancreatic juice studies, because trying to detect these microscopic pannins, and most of which are low grade and not too concerning at all, but those high grade ones we're concerned about progressing. So that was a point of emphasis. And of course, so when you're surveilling these patients, you can't just hone in on the cyst. And in fact, most of the time, the cysts that we see in these patients are not one big concerning cyst, although they can occur. It's a lot of little cysts, probably some of them which are pannins. And again, you're looking at the whole gland because the pancreatic cancer can occur anywhere.
And then there were a handful of people from the study that had resections ultimately for what was only low-grade dysplasia. So what do you think about those? Are they worth it? Is what we got from the other people worth those maybe unnecessary surgeries?
Yeah, and we've certainly gotten better selection of people for surgery. A lot of expertise, multidisciplinary conferences goes into these decisions with review with radiology and surgery and GI, et cetera. And so I think that there's a judgment about not wanting to wait too long for a concerning lesion, and that balancing that risk, it means that you're always going to end up with some examples where you have, by imaging, a worrying looking lesion, and you don't know the grade of dysplasia that's going to be in the gland, and sometimes it is only low grade dysplasia. You're asking the question because, as you know, when there's only low-grade dysplasia, the likelihood is that those lesions don't have a high probability of progressing. It's not zero, but kind of the conventional wisdom, which is sort of a simple conclusion, but mostly correct, is that it would have been better if we had a way of knowing that that was just low-grade dysplasia and left it alone. Thankfully, we only had a few of those cases in the overall scheme of things. I think patients are understanding that there's that uncertainty there, and you're trying to prevent further trouble. So,
yeah, I was curious about when in the scheme of things those surgeries happen, because I agree with you. I think by and large, there's more tools in the tool belt now to figure out what's high risk and what's not than there was, even just a few years ago, especially with like molecular testing of the cyst fluid and all that sort of thing.
Yeah, but yes, that's right. That's correct. Cyst fluid molecular testing is valuable. The thing is that some of these are low-grade dysplasias in Panin, and so they're kind of sometimes solid lesions that are concerning, not necessarily cystic, that generate that concern. Is there a focus of cancer there that a fine needle may miss? And so that's why there's these cases. In cyst fluid, if it's an IPMN, you like to think we could do better, but even then, I think the cyst fluid is not perfect. So there are always going to be some of those examples. And sometimes maybe you are preventing progression, but maybe for the most part, not.
All right, so let's get to the big question. What does all of this mean with respect to pancreatic cancer surveillance recommendations? Is this a slam dunk? Should everybody be getting screening now? Where do we go?
Well, it's a risk benefit and a cost benefit question. So that's what makes the current guidelines, some of the other organ systems that have much higher incidence of whether it's breast cancer or colon cancer, and they could sort of have pretty uniform recommendations for the population based on simple criteria like age. When you have pancreatic cancer being many-fold less in incidence, the average incidence in the population currently lifetime is 1 in about 63, and that's spread out over decades. Breast cancer is I think it's 8 times higher incidence approximately in the average. And so if we were to scan everybody on an annual basis, not only would it cost way, way too much, we would end up doing a lot of harm, even just getting these scans and these incidental findings that create a lot of anxiety. They're often of trivial, true concern, and going down chasing concerning findings that may not mean anything. So it's not we just like to be exclusive. We're trying to balance the risk. And of course, we shouldn't be the entire gatekeepers about who should get surveillance. But it is a very careful, nuanced question about what level of risk is appropriate for what is really a significant amount of surveillance, to undergo annual imaging of your pancreas or as the tests evolve. Again, it would depend also on what the nature of the test is. All this surveillance is all based on MRI and endoscopic ultrasound-based imaging. So I don't think at the moment there's going to be a fundamental change in who should be screened or at what age we should start screening. The data is highlighting much more definitively that in a high-risk population, you can make a huge difference in preventing pancreatic cancer death if that occurs. And so we shouldn't be too restrictive either. I know there's big interest, for example, in whether we should be using a family history guideline for some of the mutation carriers, like the BRCA mutation carriers. Just to underscore that a little bit, I think a lot of centers are now doing surveillance, again, based on recent data like ours, which we've been discussing at meetings over the course of the last year. But it's worth bearing in mind how the CAPS program started. When we started the program in the late 90s, it was first, do no harm. Second, could we really do this successfully? Third, the incidence of pancreatic cancer is so low that we're going to have to screen the people who are the highest risk to be able to see much evidence that what we're doing is worthwhile. So we wanted to enroll the highest risk individuals in the beginning, in the early years, people who not only had a gene mutation like a BRCA2 mutation, but who also had a significant family history of disease, whom it was most evident, most clear that they were at the highest risk. So I think we don't have a risk estimation as an exact science, but I think there's enough data to suggest that if you have a family history of a pancreatic cancer and you have a BRCA2 mutation, based on some of our data, well, we'd understand, of course, the risk is higher. But we think the lifetime risk of pancreatic cancer in someone who's a BRCA2 mutation carrier or an ATM mutation carrier, for example, is sufficiently high to warrant surveillance. It's probably in the order of 5% or so, which is a useful cutoff, I think, for this kind of surveillance.
So just to clarify, you feel like screening is appropriate for mutation carriers in the presence of family history. Would you advocate for screening without family history at this point based on this data?
Well, so yes, for example, for select few genes, it all depends on the gene, right? So BRCA2 and ATM, for example, we already recommend surveillance, for example, for CDKN2A mutation carriers at very high risk. But for the BRCA2 and ATM, we actually have been recommending surveillance within the CAPS program ourselves. We haven't seen it since the guidelines, but in the last a couple of years, we have been opening it up. Again, the CAPS study is a cohort study which will allow us to address this question over time. So I wouldn't say we have a definitive answer about its merits, but I think just our clinical judgment and based on what we know about risk in this group, they do warrant, as you know better than I, right? Family history as a guide is imperfect, and we're now much more in the game of trying to be inclusive where possible. I think, there's a lot of reason to believe that these patients would benefit.
I think that makes sense. One thing I found interesting about that ASGE recommendation is that with BRCA1 and BRCA2, whereas the data would suggest ATM and BRCA2 might make more sense.
Right. I totally agree with you. I think the challenge for BRCA1 mutation carriers is their risk is lower. As you know, it's 2 to 3-fold life elevated relative risk. So that puts it at a relatively lower risk of under 5% compared to BRCA2 or ATM. Our registry data with Dr. Klein and some other centers published a paper in JAMA Oncology about ATM risk last year and their lifetime risks. Again, we need more studies of this kind, but the lifetime risk is perhaps in the 10% range, independent of family history. So BRCA1 is clearly a different category. On the other hand, these patients are getting surveillance for other cancers. And so it would be great if there was a simple way of incorporating pancreas into that surveillance. But if they were just having a standalone surveillance, and there is that burden of other surveillance as well at the same time, that it's clearly a different level of risk. Where you draw that line is something that we get together as experts and try to make good judgments about. Their trade-offs.
Absolutely. To expand on that, thinking ahead, what do you think are next steps? Is CAPS-5 continuing? Will there be a CAPS-6? Where do you see this going from here?
We're trying to maintain CAPS-5 study thanks to our funders to help provide this multicenter infrastructure. It's not like we've answered all the major questions. We have a lot of important work to do, optimizing surveillance intervals, identifying blood tests that could potentially be of value. In the Hopkins Center, at our center, we begun using a tumor marker gene test that is part of a clinical trial that we're funded for by the NIH and an R1, and we'd like to be able to expand that to other centers. It's helping us to utilize one of our tumor markers better. So we're evaluating that, and of course, there are other blood tests that are undergoing evaluation. In the context of surveillance, I think we need a low-cost and highly specific and accurate test. And it's not likely to replace the imaging because the imaging is able to see these very small stage 1 pancreatic cancers. And the blood tests we're considering, it may end up being an adjunct, but not a replacement. Okay. So there's things like that. We're certainly trying to support the CAPS program through our efforts, getting funding from wherever we can. There are some other interesting things that we're doing. We have a small pilot vaccine trial that we're testing out for immunoprevention. There's lots of things to understand about how to do a better job at surveillance. We have to keep trying to find new susceptibility genes, as I'm sure you'd be interested in. It's been quite challenging to identify additional genes that would help us in the clinic. But we keep trying.
That all sounds fantastic. Well, Dr. Goggins, it has been a pleasure talking to you. I've really enjoyed our conversation, and I hope that our audience has as well, and that they'll be as excited as I am about what this paper means.
Well, Beth, thanks very much for having me, and it's been great working with you and Dr. Brandt and the team at Pittsburgh, and look forward to many good years working together.
Thank you.
Thank you.